Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I am Professor Numan Nafie and I will give you the fourth lecture in neonatology. That is the neonatal birth traumas or injuries, and then the other part is the neonatal scissor. The neonatal birth traumas and neonatal scissor objectives are to know what is meant by birth trauma and their risk factors and their evaluation, and to describe the types of birth injuries in details, and to know what are the definition and causes and risk factors of neonatal scissors, and to describe the clinical presentation, diagnosis, treatment, and prognosis of neonatal scissor. Neonatal birth traumas, they are avoidable and unavoidable injuries to the neonate that occur during birth process. And the birth traumas now are less common or less frequent because of more use of cesarean section and all over the world, especially in Iraq. They can occur during prenatal, natal, and even postnatal period. And this is one example of birth trauma, which is called ribs palsy. When there is shoulder dystocia, there will be traction on the shoulder and causing injury to the cervical plexus C5, C6, and causing internal rotation of the forearm and adduction of the arm and flexion on the wrist, called ribs palsy. What are the risk factors for birth injuries, including being a primary mother, maternal pelvic anomalies, prolonged or unusually rapid labor, because rapid labor also will force the baby to pass rapidly and causing injury, oligohydramnios, malpresentation of the fetus, use of mid-forceps or vacuum extractor, the external internal version and extraction, being very low birth weight also exposed to birth trauma or extreme prematurity, the being large for gestational age baby or fetal macrosomia or large fetal head also might predispose to birth trauma, and as we said in the previous lecture about large for gestational age babies. And then some fetal anomalies can also cause birth trauma. The evaluation of birth injuries or traumas, including detailed history, then thorough physical examination and including neurological examination, and we have to pay special attention to the symmetry of structures and function, and then cranial nerves and the range of motion of joints and integrity of the scalp and skin. Types of birth injuries include soft tissue injuries, nerve injuries, fractures, visceral traumas, and including most commonly the liver, then the spleen, and then the adrenal. And then we have the intracranial hemorrhages and neonatal cold injuries. Neonatal cold injury occur postnatally. It is not a trauma, but due to exposure to improper cold atmospheric temperature. Soft tissue injury, first we have the caput succeedinum, and this is a fluid collection over the presenting part when head presentation. They appear immediately after the delivery and disappear within a few days. It is not limited to suture lines, and it requires no treatment. While cephal hematoma is blood collection under the periosteum, and it is limited to suture line mostly on the parietal bones, and it could be bilateral, and in 5 to 20% of them they might be associated with fracture of the skull. For this reason, CT scan might be indicated. And cephal hematoma also require no treatment. Just leave it; it will disappear within few weeks. sometimes up to 2-3 months. It might leave calcification and never aspirate blood from it. Chignon is the bruising over the scalp after venous extraction. Bruising of the face might occur when the baby comes as face presentation, and there is ecchymosis on the face, which might be misdiagnosed as cyanosis. Bruising of the genitalia might occur following repeated PV examination in a breech presentation. Abrasion of the skin can occur at any part of the body, whether cesarean section or sometimes a normal vaginal delivery, and with the head appear on the opening of the vagina, and they might do episiotomy and can injure the baby, or sometimes injury from the iliac rods for monitoring. Then we have the subgaleal hemorrhage is a dangerous but rare condition. There is bleeding under the galea aponeurosis, and it can extend from the forehead to the neck and to the ears. It can cause anemia, jaundice, and might require blood transfusion. Severe or fatal injuries, they are rare, including torsion of the falx cerebri or tentorium cerebelli. Subconjunctival hemorrhage by itself is not of clinical significance, but we have to look for retinal hemorrhage, which is more dangerous. And this is the figure will show the different types of hematomas. The first thing is the caput, which is fluid collection, this is not blood. And then we have the cephal hematoma under the periosteum, and we have the subgaleal hemorrhage under the epicranial aponeurosis, and then we have the extradural hemorrhage here. There is this table will show difference between caput succidium and cephal hematoma. You could see that the presentation is different. Whether it is limited to suture 9 or not is different, and the consistency of the swelling is also different, presence of ecchymosis or not, the size at birth, whether it's present at birth and or not, and for how long it persists. For example, for cephal it might persist for 6 to 8 weeks or even more, while caput might persist just few days and disappear. And there might be fracture with cephal hematoma but not in caput, and there is no treatment for both conditions. Then this difference also between the caput and the cephal hematoma on this figure, and this is the caput succidium over the presenting part, which appear immediately at birth and disappear within a few days. It is fluid collection rather than a blood collection. This is also caput succidium with spitting edema. Bilateral cephal hematoma here, it is limited to suture line, so it will not cross the suture lines. Could be unilateral or bilateral, it requires longer time to disappear. This is also seen on imaging of the head, bilateral cephal hematoma. Ecchymosis of the face when in breech presentation, when there is face presentation with, for example, PV examination, they will cause bruising on the face and causing bluish discoloration, which might be misdiagnosed as cyanosis. This is bruising of genitalia when there is breech presentation, and repeated PV examination will cause laceration of scrotum. Iatrogenic scalp injuries by scalpel anywhere, could be in the face, on the shoulder, on the buttock. Bruising at the site of venous extraction. This subgaleal hematoma, it is rare but is dangerous and can be fatal. The other type of injury other than soft tissue injuries is the nerve injuries. We have brachial plexus injury, which could be upper or lower part. The upper part involves the C5, C6 called waiter tip posture, and the lower part of the brachial plexus involving C7, C8 and T1. And we have also the facial nerve injuries and phrenic nerve injury. The brachial plexus injury occur due to traction to the cervical nerve root. They may occur after breech delivery or with shoulder dystocia. Erb's palsy, or called waiter tip posture, involves C5, C6. The Moro and biceps reflexes are absent, but grasp reflex is preserved. Klumpig's palsy involves C7, C8, T1. There is weakness of long flexors of the wrists and fingers and intrinsic muscles of the hand. The grasp reflex is absent in this condition. Treatment by immobilization for 1 week, then with passive range of motion exercise of all joints of the limb. It needs physiotherapy starting from the 2nd week of life to prevent contractures and Erb's palsy. Most palsies resolve over a few weeks. Occasionally, following severe injury, the paralysis might be permanent. Other nerve injuries include facial nerve injury. It is the most common peripheral nerve injury in neonates. It may result from compression of the facial nerve by forceps blades or against mother's pelvis. It is usually transient, seen as asymmetric crying face. When the baby cries, there will be asymmetrical face. A phrenic nerve injury involves C3, C4, C5 cervical nerve. There is ipsilateral diaphragmatic paralysis, and 70% have brachial plexus injury, and patients will present with spastic stress cyanosis and the diagnosis by ultrasound and fluoroscopy. This is as Erb's palsy, as we mentioned. And this is a rare condition where following birth you could see a swelling over the sternomastoid tumor, sternomastoid muscle called the sternomastoid tumor. It is thought to be due to bleeding inside the muscle, and this bleeding will heal and absorb and leave fibrous tissue, and this fibrous tissue will cause swelling, and this may cause contracture over this muscle and lead to torticollis. This is facial nerve injury, and this is left facial palsy because the angle of the mouth is pulled toward the right, so the left side of the face is paralyzed. While this is right facial nerve palsy, where the angle of the mouth pulled on the left side by normal muscles and side. Other birth traumas, the fractures. We have fracture of the skull, fracture of the clavicle, and fracture of the humerus and long bones, and even there is fracture of ribs. And this is normal anatomy of the sutures and skull bones. We could see the anteriorly the metopic suture, coronal suture, and then sagittal suture, lambdoid suture, and we have the anterior fontanelle and posterior fontanelle. Fracture, skull fracture, they are rare, usually linear, and usually on the parietal bone. Depressed fractures usually occur on the parietal or frontal bones. They are unusual. If no neurological deficit, no treatment. If neurological deficit, we need to do CT scan, and there might need surgical removal, surgical elevation of the depressed fracture. Fracture clavicle, usually from shoulder dystocia. You may hear a snap during delivery of fracture, or infant may have reduced movement of the arm on the affected side because of tenderness of fracture, or you may feel a lump from callus formation of fractured clavicle, and the prognosis is excellent. Fracture of the humerus and femur, usually mid-shaft, occurring at breech presentation. They present with loss of spontaneous arm or leg movement, pain and swelling in a passive movement if displaced. This is depressed skull fracture here. If it is causing neurological deficit, it needs CT, and we might need to do surgical elevation of this fracture. Displaced fracture of the left humerus. This fracture, all the fracture of the ribs because it's calcified, and all the fracture of the right clavicle, and there is 2 fractures on the left side of the chest, fracture of the ribs. There's different types of fractures here. It's fracture humerus, fracture over the elbow, fracture femur, and fracture of the skull. The visceral trauma, they are trauma to the liver and spleen and adrenal. They are uncommon, seen in macrosomic infants and in very premature infants with or without breech or vaginal delivery. They may be asymptomatic or present with shock, pallor, jaundice, and they are diagnosed by ultrasound. Subcapsular hematoma of the liver is the most common type of the visceral traumas, and it may follow macrosomia, large for gestational age babies, or because of hepatomegaly, or during breech presentation and delivery. It is suspected if the infant have anemia, hypovolemia, shock, and there is no evidence of intraventricular hemorrhage, and there is no other external bleed, and there is no IVH. It is usually seen in 1 to 3 days after birth, and we need to do serial PCV. There will be decline in the PCV, and there is no external bleed, and there is no IVH. We should think of subcapsular hematoma of the liver. And management by restoring blood volume, correct coagulation disorder if present, and surgical consultation. They probably do laparotomy to stop bleeding. Other birth traumas are the intracranial hemorrhage, and we said they are either subedural hemorrhage, subarachnoid hemorrhage, periventricular, intraventricular hemorrhage, and intraparenchymal hemorrhage, and or intracerebral hemorrhage. We talked already about intraventricular hemorrhage, but other types are the subdural hemorrhage. It is usually seen in association with birth trauma, cephalopelvic disproportion, in a large for gestational or macrosomic babies, after forceps deliveries, after they will have associated with skull fracture, and there might be postnatal head injury, and which is not seen or by the mother or the parents. It may be asymptomatic initially, but as the RBCs undergo hemolysis, the water is drawn into the hemorrhage, resulting in further expansion and being symptomatic mass. They present with anemia, vomiting, seizure, enlarging head, and occur in infants who are 1 to 2 months old, and they later discover to have subdural hemorrhage. Occasionally, massive subdural hemorrhage in neonates by rupture of vein of Galen or inherited coagulation disorder as hemophilia. Treatment of all symptomatic subdural hemorrhage is surgical evacuation. And this is one of the epidural hemorrhage here, and there is epidural hemorrhage A here, the first one. There is also intraparenchymal bleed, and here there is intraventricular hemorrhage, and also intraparenchymal blood in the middle X-ray, and then we have the in the MAJ C also showing intraventricular blood in the occipital horn of the lateral ventricle. This intraaxial hemorrhage, there is in A there is intraventricular hemorrhage, and in B there is choroid plexus and intraparenchymal hemorrhage. And here we could also see in CT scan of the brain will demonstrate epidural hemorrhage, subarachnoid hemorrhage here, and intraparenchymal here and here. While on the other side there is MRI of the brain which demonstrates bilateral subdural hematoma. And this is one study done outside. It will show the incidence of different birth injuries. The most common is caput succedaneum. It represents about 16% of 17.6%. The less frequent injuries are cephal hematoma, ocular injuries, fracture clavicle, fracture femur, fracture ribs, ribs palsy, ecchymosis, and lacerations and excoriations. Neonatal causal injury, as we said, it is not birth trauma. It is the injury which occur to the low birth weight preterm babies, and sometimes in a full-term babies with CNS disorder due to inadequately heated homes and damp cold spells. They present with apathy, refusal to feed, oliguria, coldness to touch, and low body temperature, 29.5 to 35, which cannot be detected by ordinary thermometer, but you need to use low reading thermometers. They also have immobility, edema, and there is redness of the extremities called scleremia. All scleremia, they are cold, they touch cold and red and hard, called scleremia. They might have developed serious metabolic disturbances, especially hypoglycemia and acidosis, and hemorrhage, especially intrapulmonary hemorrhage, might occur, which is associated with high mortality. How we manage patients with neonatal cold injury? By gradual rewarming, by correcting hypotension, by normal saline, we correct hypoglycemia, correct metabolic disturbance, treating infection and treating bleeding if present. Prevention, we have to provide adequate environmental temperature if possible. The outcome, 10% mortality or even more, and 10% of the survivor got brain injury. We finished the birth trauma. We'll talk now about the neonatal scissors, and you have to take this quiz. 12 hours old full-term neonate, the result of prolonged difficult labor, came with frequent convulsions. The Apgar score was 1, 4, 8 at 1, 5, and 10 minutes. You need active resuscitation in the delivery room with a bag and mask and chest compression. What is the most likely cause of his convulsion? Is it perinatal asphyxia and hypoxic ischemic encephalopathy, or intracranial hemorrhage, or toxic exposure because of local anesthetic injection for episiotomy or for other reason, drug withdrawal, or infection like meningitis and encephalitis? Quiz 2. A consultant in the neonatal intensive care unit is recommending trial of pyridoxine for a patient. Which of the following problem in newborn infant might respond to pharmacological dose of pyridoxine? They use pyridoxine for blindness or seizure or jaundice or rash or urinary retention. So neonatal seizures are defined as clinically, they are defined as paroxysmal alteration in neurological function, and the incidence varies from one country to another, from one center to another. They are not uncommon. The causes behind neonatal seizures, the most common cause is perinatal asphyxia or hypoxic ischemic encephalopathy. Less frequent is the intracranial hemorrhages, we already mentioned. Metabolic abnormalities, hypoglycemia, hypocalcemia, electrolyte disturbance, hyponatremia, hypernatremia, amino acid disorders, or inborn error of metabolism. Infections like meningitis, encephalitis, syphilis, CMV infection, toxoplasma, and cerebral abscess. Other causes include drug withdrawal, toxin exposure, as we said, inherited seizure disorders benign familial epilepsy, tuberous sclerosis, Zellweger syndrome, and pyridoxine dependency, and then the congenital malformation of the brain. These are the causes behind most of the cases of neonatal seizures. And this is radiological or imaging study showing hypoxic ischemic encephalopathy. This is T1 weighted sagittal image of the brain, demonstrate lamellar necrosis and diffuse hyperintensity of the basal ganglia and thalami. And B, there is T weighted axial image of the brain, demonstrate laminar necrosis and diffuse hyperintensity of the thalami. How they present? Neonatal seizures, it's important to understand that seizures in the neonates are different from those seen in older children. So you have to be careful. Neonatal seizure is something different from seizures in older children and adults, because the anatomy, the physiology, the pathology is different, and partly because the myelination is not complete. So the connection between the higher center and lower centers might not be complete. 4 types of seizures based on clinical presentation are recognized. The most common is subtle, less frequent is the clonic, tonic, and myoclonic. And each of these types, they have subtypes. Neonatal seizure is very important to distinguish from jitterness. Jitterness is not accompanied by abnormal eye movement. Movements cease on application of the passive flexion, and the jitterness are stimulus sensitive and are not jerky. Diagnosis of neonatal seizure by history, very important, especially family history, which might indicate metabolic error, or there might be benign familial neonatal convulsion. Maternal drug history, narcotic withdrawal syndrome. History of the delivery, because trauma, for example, can cause seizure. Physical examination, thorough general examination and neurological examination, and during examination we have to take in consideration the gestational age, the blood pressure, the presence of skin lesions, like neurocutaneous syndromes might be associated with seizures. Presence of hepatosplenomegaly, like in congenital infections, might also cause seizure, like CMV and toxoplasma. Neurological evaluation is very important, and notation of the seizure type. Notation means we have to document the seizure by witnessing or by video, and recently they are now doing 24-hour video monitoring of the patient. In addition, they are using what's called amplitude EEG to diagnose neonatal seizure. Also, we might need to do laboratory studies, including serum chemistries, blood sugar, serum calcium, serum phosphorus, serum magnesium, serum electrolytes, acid-base balance, IBG, sorry. If we suspect meningitis, encephalitis, we need to do lumbar puncture and CSF examination. Metabolic disorders investigation, like blood ammonia level, urine and plasma amino acids, and urine for reducing substances. Radiological examination, like ultrasound of the head, especially for intraventricular hemorrhage, might be beneficial, but we might need to do CT scan for other types of hemorrhages or other, and even MRI. Other studies, EEG is very important, and we have the conventional EEG, and we have the cerebral function monitor, or amplitude integrated EEG, which is a device used to measure the background electrocortical activity in the brain. The cerebral function monitor provide information on global cerebral activity to indicate the generalized level of electrical activity occurring across the entire brain. So how we manage patients with neonatal seizure? Because repeated seizures may lead to brain injury, urgent treatment is indicated. the method of treatment depend on the cause. Also, first we should look for common and treatable causes because they are easily treated and can stop convulsion or a seizure, like hypoglycemia, hypocalcemia. Hypoglycemia, we give, for example, dextrose infusion, calcium hypocalcemia by giving calcium gluconate 10% by infusion also, and monitor the patients, and might, once the convulsion stopped, these common correctable and treatable causes we might stop, which might stop shortly within hours or few days. If there is no common or uncorrectable causes, still in the patient convulsing, we need to give anticonvulsant drug, and still the phenobarbital is the drug of choice for management or treatment of neonatal seizure. Other drugs including phenytoin, and if there is no response to adequate doses of phenobarbital and phenytoin, we might think of giving pyridoxine trial with EEG monitoring, because abnormal EEG might be normalized with slow infusion of pyridoxine. Diazepam is not that used commonly in neonatal seizure. Lorazepam is more used and can be effective even if it's given over 46 hours, daily. Intravenous midazolam and oral carbamazepine might be promising, and paraldehyde, an old drug that still effective and might be used in certain countries. The conventional anticonvulsant treatment is used when there is no underlying metabolic cause is found. Loading doses of phenobarbital and phenytoin control 70% of neonatal seizure. Phenobarbital is usually given first. When phenobarbital alone fails to control seizure, another agent is used. If seizures are not controlled at serum phenobarbital level of 40 microgram per ml, it is recommended to administer second agent, phenytoin. Phenytoin is used next by many practitioners. Phosphenytoin may be preferred form. Pyridoxine trial with the EEG monitoring is recommended sometimes. Diazepam has not been used extensively in the control of neonatal seizure. Lorazepam given intravenously has been quite effective and safe even when repeated 4 to 6 times in 24 hours. Intravenous midazolam and oral carbamazepine have been found to be effective. Paraldehyde, an old drug, can be given rectally or by IV infusion, can also be effective. The duration of anticonvulsant therapy, the optimal duration of anticonvulsant therapy has not been established, although some clinicians recommend continuation of phenobarbital for a long period, even for 3 months or even up to sometimes to longer than 3 months. Others recommend stopping it after seizure had been absent for 2 weeks. The prognosis of neonatal seizure, the mortality rate has decreased from 40 to 20%, but the neurological sequelae are still high, about 25 to 35% of cases. The prognosis depends on the cause. For example, infants with late hypocalcemic convulsion, they have excellent prognosis, 100% improvement. Seizure secondary to congenital malformations have poor prognosis. Symptomatic hypoglycemia have 50% risk of death or complication. CNS infection carries a risk of 70%. Asphyxiated infants with seizure have 50% chance of poor outcome, and 17% of patients with neonatal seizures have recurrent seizure later in life.